So we took a quick break. We were talking to Dr. Patel in our previous episode about MSA versus PD versus PSP. So kind of like all the different variations things that can look like Parkinson's. Mm-hmm. Now we want to talk about the differences with dementia. So dementia is, I would say, what, the category?
Right. So dementia is just a symptom. Right. So
Okay.
you think of dementia as having memory issues. So what I tell my patients usually is, after the age of 30, everyone's brain starts to shrink.
Mm-hmm.
So
That's really kind of sad. After 30?
Right. So there's this normal age-related memory issues, right? Forget where you put your keys, you walk into the room, what did I come here for? Those sort of things, very, very typical for age.
But you can remember every 1980 song that you ever heard. Word for word, you can repeat
It's usually short term.
Yeah, because you can repeat every word from a 1980 song, but you can't remember where you left your keys.
Right.
That is interesting.
Or name. So naming is the first thing. People come to me for saying they have memory issues because they can't remember names, and that's an age thing. It's very common. And then there's the question, well, what is not normal for age? And that's where these neurodegenerative dementia-like things come into play. No, the most common neurodegenerative disorder is Alzheimer's, more than Parkinson's, right? Mm-hmm. So Alzheimer's disease is the most common. And then you have Parkinson's dementia, you have Lewy body dementia, you have frontotemporal dementia. So there are different categories of different vascular dementia. There's different types of dementias that are out there.
So let me ask you this. Just because you have Parkinson's, that does or does not mean that you will get Parkinson's dementia?
Does not.
Can you have Parkinson's disease and get a different kind of dementia?
Yeah.
Okay.
Yeah.
So
Just because you have Parkinson's doesn't protect you from getting Alzheimer's.
So what's Parkinson's dementia versus Alzheimer's?
So Parkinson's dementia is a condition. Usually patients have Parkinson's for at least probably 10 years, I'd say.
Okay.
Where they have the motor features, they go through their ups and downs, they're progressing.
And not from diagnosis, 10 years of the symptoms.
Usually symptoms,
okay.
Yeah. And then you start noticing, so the common key points for Parkinson's dementia is usually hallucinations.
Not medication related, disease related.
Both.
Oh.
Both.
Okay.
So usually they would say, they're very stable on their meds. Mm-hmm. And then all of a sudden, hallucinations are picking up. Paranoia specifically towards the significant other. So they tend to kind of latch on, or if the significant other's at the grocery store or getting things, you may get called all the time saying, where are you? What are you doing? Mm-hmm. And there's this paranoia related to that. There's this, impulse control disorder where, excessive shopping, eating, gambling, those sort of things may start kicking in. But most of the time, Parkinson's dementia patients are aware that this is happening. And they will tell you that this is happening. Compared to, say, an Alzheimer's patient who generally Alzheimer's patients don't have the insight to the fact that they're having issues. It's everyone else telling you that, hey, they don't remember. That's not true. They don't remember. And they think life is completely fine. They're perfectly fine. They can drive. They can live alone. They can do this. And everyone's like, no, they can't. And so that there's those key differences. So an Alzheimer's, a pure Alzheimer's patient isn't going to have obviously the motor symptoms associated with Parkinson's. So a Parkinson's disease, the Parkinson's dementia patient is going to have Parkinson's. They're going to go through their motor symptoms and non-motor symptoms, usually at least for about 10 years. And then you're going to start noticing some more short-term issues, just slower processing. Like with Parkinson's, everything slows down, right? So whether you notice, it takes you longer to get the word out, what you're thinking about, or what was the topic or whatnot.
Is it more executive functioning?
Usually.
Okay.
And then you may start noticing, again, whether it's, and most of the time the hallucinations are not bothersome for the patient. They're they're small little bunnies or cute kids or whatnot, and they're fine with it. They're like, yeah, I see that. That's fine, and they know it's not real. They understand it. It's you act on it or you treat it whenever the patient starts saying, whenever they're acting on it. So they're calling the police because there are kids in the yard that shouldn't be there, or they're out chasing things that are not there, right? So that you want to kind of address and treat. But those are extremes.
But that's not Lewy body.
Lewy body is, you could have that, but you have that much earlier. So usually, if you're going to think about Lewy body disease, is either they're having memory issues before they started having their motor symptoms, or they had their motor symptoms, and usually within the first 4 or 5 years, just like differentiating MSA, PSP, Parkinson's, Lewy bodies looped into that category, is that within the first 4 to 5 years of diagnosis or before their motor symptoms, they're going to start realizing that they're already hallucinating. They're having memory issues. REM behavioral disorder, which is where you yell, scream, shout in your sleep, you're acting out vivid dreams in your sleep. The patient has no idea they're doing it. Usually the significant other is taking the brunt of it and is getting hit and kicked and whatnot. And that stuff is happening much earlier than it would for a Parkinson's disease patient. So if you start noticing that, or your doctor generally should be asking you these questions at every visit, whether you're doing this. And if you start noticing, okay, your tremor just started a year ago or whatnot, and you're already on minimal meds, and you're starting to hallucinate, you're starting to do this, you're starting to question whether this may be Lewy body disease. But within the first few years, or on minimal medications, and it's starting to happen already. But Parkinson's disease patients, when they start doing it, and like you mentioned, it could be medication related. So step one is always try to minimize the amount of meds that you possibly need. Because if you look at any of the Parkinson's disease medication side effects, it's going to be hallucinations. It's going to be, all these things are all going to be there. So step one is try to clear out the water as much as possible. The least amount, the medication that causes the least amount of side effects is carbidopa-levodopa. So when my Parkinson patients are starting to do this and it's becoming a problem, step one is to get rid of anything that is not carbidopa-levodopa.
Okay.
And sort of, because those meds are probably now at this point causing more side effect than benefit.
Okay.
So you clear up the water. Whether you need to give them more levodopa to replace it, depending on how their motor symptoms are going, you can. But usually at that point, their motor symptoms have stabilized, and so you could get rid of a lot of stuff. So kind of maintain them on just a regimen of carbidopa-levodopa. And then if they're still having issues, you could talk about, there are lots of different options in terms of treating memory issues and hallucinations and REM behavior disorder.
Wow.
It's a lot. It's a lot.
That's Brian's biggest thing all day today.
No, I mean, there is a lot. There's just a lot to take in there, and it's a lot to worry about, and a lot to think about.
It is, but I think like that's why, I mean, I started researching it myself because, I see different things with different Parkinson's patients, and I'm not a doctor, so I don't know any of the stuff. But I just, no, I don't. I mean, Dr. Jess, that would be nice. But, I question these things not for myself, or at least not yet, but for
this is why I don't do research.
This is why you never have any questions to ask. No, but just to help other people going through it, because to your point with Alzheimer's, your family members or friends are seeing it, right? And
yes.
They're the ones, telling you or talking to the doctor. But like for Parkinson's dementia, if they're the one, like if that patient knows that it's happening, is it something that their caregivers then don't necessarily see?
No, they can, and it's not like the Parkinson patient may be seeing it, but they may be in denial, or they don't want to talk about it. A lot of times it is that. It's like I would ask the patient, "Oh, are you hallucinating?" And they would say, "Yeah, yes, I am." And the family member would be like, "Wait, what?" Like you never say it, and because they don't want to say it, they're embarrassed by it, they're scared.
Yeah.
Right, and so it's but they have insight to their disease, right? But it can come to a point, if you had Parkinson's for so long, that you do lose that insight. And again, just because you have Parkinson's doesn't prevent you from getting Alzheimer's. So, I do have patients that they have Parkinson's, they're stable, all of a sudden there's this rapid, fast decline in their cognition and their memory. And it's like, okay, well, maybe there's something else going on here besides just Parkinson's. And they just go downhill really fast, and that may be whether something else is going on. Now, a Parkinson patient, again, is going to be much more sensitive to certain things. So if a Parkinson patient is admitted to the hospital for whatever reason, they may become delirious. So there's delirium versus dementia. Delirium is temporary. Delirium is just confusion that isn't going to be permanent. And delirium can happen much more commonly in Parkinson's patient. And just because you become delirious after a surgery or you're in the hospital, why am I here? What's going on? That doesn't mean, oh my God, you have Parkinson's dementia. That's temporary. That's from the stress that the brain is going through because of a UTI or surgery or whatnot. That will resolve and you'll go back to kind of how you were. When the dementia kicks in, that's sort of starting this progression downwards that doesn't necessarily resolve per se. We could try to slow it down with meds. We could try to stabilize it. It's how patients, dementia medications are there because you're starting to see this slope going down of this patient's, your family members declining. And the idea is then to sort of lessen that slope. And that's all the med is really doing, is sort of making it so it's not just this rapid decline, but rather just a slower progression.
So do you think, like what a lot of what we do and what we hear from people that watch is, they're not educated on a lot of different topics that we're bringing up, which we're not educated on them either, which is why we asked the question. But I don't know why I never thought like you can have Parkinson's and get Alzheimer's as something separate. Have you had patients that you've had to diagnose them with the other, and were they like shocked?
So the Parkinson patient, unfortunately, if they get, so again, with Alzheimer's, you lose the insight. So the patient doesn't realize it. Right? So they think, I have Parkinson's and life is fine.
Yeah.
And everyone's like, no, it's not fine.
Yeah.
This is what's happening for them.
Just give me a shot.
But I mean that's you me, right?
Yeah.
That's the case for
Derek and I will take care of you.
Yeah, I don't want anybody to take care of me.
We'll take care of you and put a pillow over. No.
It's one of those like, okay, I have Parkinson's, I'm done. Nothing else is going to happen.
Well, but that's the thing. Like, but my question is,
I can't get cancer. I have Parkinson's. I'm indestructible now.
But the thing is, like, so I know you said, that their caregiver, somebody will say, no, there's other things going on, but there are some caregivers that are in denial themselves, so they're just focusing solely on Parkinson's. Or could they be overlooking the Alzheimer's piece?
Of course. And that's, but usually whenever you have that rapid decline, it's hard to overlook it.
So, like, you would notice it?
Yeah. Okay. Because you're obviously, you're afraid for your loved one, right? You're scared for their safety.
Yeah.
And you're scared to leave them alone because what if they leave the stove on? What if they start walking around outside wandering in the middle of winter? And you start realizing that I need to be more present because I don't feel like they're safe.
Right.
And so a lot of my Alzheimer's patients, it's usually the situation where the caregivers are actually sometimes afraid to bring it up, right? Because the patient's going to say, no, I'm fine.
Yeah.
And then it leads to, obviously, there's arguments then, and you become, there are issues. So they would, it's funny because what would happen most of the time is I will usually get a note or letter before my appointment from the family member saying, hey, I need you to bring this up because they're scared. So I have to be the bad guy and bring it up.
Yeah.
Be like, hey, I hear you're doing this. And they're like, no. I'm like, well, I think it's happening. And you need to kind of address it. And the family member's just quiet, like, I didn't say it, but they did.
Yeah.
And so...
but I think it's important for people to know that they can do that too.
Yes.
And that's sometimes the only way and the best way to get around that awkward
Right, and ultimately, everyone's goal is always the same, right? Is to protect and take care of the patient, their safety and their health, right? And that's the goal, and that's what everyone's trying to do. And loved ones are doing the same thing, and caregivers, and with dementia, a lot of times, the biggest thing and the biggest impact is caregiver burden, right? Like caregivers are the ones that are much more not much more affected, but they're living with the day to day. I'm seeing this patient once every few months for half an hour, whatnot, right? That's my impact. But that patient's going home to their loved ones, and they're the ones that are like having to deal with this. Okay, remember, you can't leave, you can't do this, we're going to do this. And they're the ones that are constantly repeating themselves. They're the ones that are constantly, they have to go through that and live that life, and it becomes very, very difficult.
So from a caregiver standpoint, like if you were to share with people today, like what are things that they should look for to then talk to the neurologist at the next appointment to maybe determine, is it Alzheimer's, is it PD dementia? So
Parkinson's dementia, again, if you start, as a caregiver, if you start realizing that your loved one with Parkinson's is like, wow, they keep calling me. They keep saying, they're like, oh, you've been gone for too long. Where were you? What are you doing? Like something that's inappropriate or that's not out of the norm.
Yeah.
Obviously bring it up. If you start realizing that they're hallucinating, if you can't stay in the same bed with them because you're being attacked while you're sleeping.
Oh, with the REM.
With the REM behavior disorder, right? Like that's still a quality of life thing.
Yeah.
You want to be in bed with your significant other. You don't want to sleep in a separate room.
Yeah.
And if the patient doesn't know they're doing it, and that's happening. And so you want to kind of bring that up and address it, like, hey, I'm being kicked and punched and hit. And so they're the ones that are losing sleep. The Parkinson patient's sleeping just fine. They're doing this during their sleep.
Well, that's opposite at my house. Derek's getting great sleep, and I'm up every 5 hours or every 2 hours.
So you want to bring that kind of stuff up. If it's Alzheimer's, obviously, certain things to bring up. One thing with Parkinson's specifically, especially if they're on like dopamine agonists or certain medications, the impulse control thing, Parkinson patients may not realize they're doing it. They're craving sweets. They're increasing gambling. They may be slightly more hypersexual. They may start spending more money than they normally would be. And it's we as clinicians, physicians, we rely on caregivers to tell us, hey, they're doing this. Yeah. This is happening more frequently than what's normal for them, and what's normal in general. And then we need to address it, because I've had patients who, unfortunately, they went through their retirement, they went through their life savings without the caregiver even knowing that this happened. There are patients. I had a patient just the other day who he answers phone calls and just starts giving out his bank account information to take donations to random people. Like, oh, I'm just donating to this cause. And the spouse like, well, what was it? Like, what do you mean? And they're on certain meds that's happening, and they think they're just doing a good thing.
Yeah.
But you have to be cautious.
So to that point, I know we've talked about this topic a number of times because that happened to me. I was on Rupinerol, but what I want people to know is it doesn't have to just be gambling or shopping.
No.
Mine was work.
Right.
I was on my computer 24 hours like throughout the night, and I would lie to my husband about what time I came to bed, and I was downstairs in my office.
It's anything you enjoy doing, and now you can't stop.
Yeah. Right. And you tell yourself you can. Well, I can turn this off. I just have a lot to do.
Like, I have a patient who just decided to redo his bathroom floor for no reason whatsoever. Mm-hmm. And that was part of it, because wife was like, why are you doing this? Mm-hmm. Or like Home Depot once in a while, but now would come home with truckloads of stuff every day for no reason whatsoever. Yeah. And it's stuff he enjoys, which is great. He wanted to remodel his house.
I
know.
You can enjoy it in my house all you want.
My colleagues and agency partners loved it. They're like, you were getting stuff done left and right. I'm like, yeah, it was very good.
Yeah. But they had to be careful, because they're like, he's spending so much money by doing this that was not safe.
So, not having trouble or not being able to recall a name, a show, an actor, is not a sign.
that
It's not a
very
sign.
much so.
Okay.
That is normal. Yeah.
Yeah, it's just normal. Okay.
That's normal.
Yeah.
Parkinson patients, obviously, you're just going to be, you do have this neurodegenerative condition going on in your brain.
We do?
So,
Shoot.
so anything that's going to cause some sort of cognitive side effect, you may be a little bit more sensitive to compared to somebody else, right? So, I mean, I think you guys had talked about, did you talk about marijuana and Parkinson's already? Was the topic?
We've dabbled.
We dabbled in it. We haven't. That needs to be a separate topic. But yeah.
But that's something I talk to my patients about. It's like, yes, it has its role. There are definitely lots of health benefits to doing it. But you're someone that may be more sensitive to potential cognitive side effects of it compared to someone who doesn't have this neurodegenerative disease in their brain.
Yeah.
So something to kind of always keep that in mind is you may be more sensitive. So that's where step one is always, when you're starting to have these issues, let's clear the water. Let's clear up the muddy water. Let's get rid of whatever we possibly could get rid of, and see how you do with that.
This is good.
Great.
I feel awesome about my future. No,
Let's end on like a positive note. Don't you have any good questions out there that you can,
no.
There was a question. What was a good question?
Constipation. Or,
this was a good question. We may have talked about this somewhere. What is your top must do, must not do to ensure a great DBS experience? The great DBS experience is going to come down to always make sure you have the right expectations.
Roz. No, we actually had her on, and she did have the right expectations because she had Steve that helped her through to say, like, don't expect perfection.
Right. And even though people tell you that, the doctors tell you that, the surgeon tells you that.
Yeah,
you're like, I'm going to get it.
Yeah. I'm going to be that one person.
Yeah.
DBS is not a cure. DBS is just another treatment option. Mm-hmm. That's all it is. The disease is still going to progress. The disease is still going to do its thing. But what not to do is, don't go into it with unrealistic expectations. Mm-hmm. You have to expect that the only role for DBS is to give you the same benefits that levodopa gives you, hopefully consistently throughout the day. Mm-hmm. That's it. Mm-hmm. If there are things that is happening to you, regardless of how much levodopa you take, it doesn't matter. DBS, going into DBS hoping that DBS will now fix that, no.
Right.
That is not the thing. And you're going to go into it in terms of DBS as a team approach. There's multiple people need to be involved. You need to be at a care center or a site that is involved with DBS, because if something happens to you and you have to go to the hospital, you want to make sure you're somewhere where there is somebody who knows that you have DBS and knows that can help with management of the device if you need be. So those are the certain things to kind of probably the most important thing to keep in mind about DBS if and when you're ready for it.
One last thing on a positive note, is there anything that you can talk to us about and like latest research or things that you feel like are not coming out, because I know it still takes time, but anything on the horizon? Any clinical trials people can be a part of?
So I mean, obviously, if you go to clinicaltrials.org and the Michael J. Fox Foundation, you'll be able to find all sorts of different clinical trials that are going on. There's always something constantly going out there. I'm hopeful. I've talked about it before. I think I'm hopeful. I've only heard positive things about the 24-hour levodopa infusion pump. Almost, a lot of patients that have had it like it, and they, even if they experience certain side effects, they want to still continue it because the benefit seems to outweigh all that. So I'm hopeful that if and when the FDA approves that we're going to have a much more of a future great experience for patients. There are new gene therapies potentially coming out there. There are different types of treatment options that I think medicine is now advancing, that we could hopefully be able to do a lot more for patients sooner rather than later.
I'm still energized by the conversation we had with Fred from the staffer of
Yeah.
Gus Bilirakis in Florida. They have the National Plan to End Parkinson's Act going through committee right now, and the biggest thing is getting it through committee to get to Congress, but they feel like once they get it to Congress, they can pass it. But that's going to bring all the agencies together, the manufacturers. They'll have a patient council, like a whole group, to literally create a strategy similar to what they did for Alzheimer's.
Yeah.
To say, all right, let's all work together, which sucks that they don't do it to begin with, but I get why. But it's, putting a plan together, and I think like with all those minds together, I mean, we have to. I've never felt more hopeful than after that conversation we had with them. So there's your positive note.
There we go. I knew I'd find it someplace.
There you go. All right. Well, thank you again so much for coming on.
My pleasure.
It's awesome to have
Thanks,
you
Dr.
every
Patel.
time. So in our last 30 seconds, I will leave you with this. There are lots of different things that are going on out there. Don't overwhelm yourself. Take it day by day. Listen to your doctor. But when it comes to things like Parkinson's dementia or Alzheimer's, even if it's MSA versus PD versus PSP, the best thing you could do is document your symptoms, document side effects from medications, share them with your doctor and your caregiver so that they can provide you with the best care possible. And always consult your doctor whenever you get a chance. Thanks for tuning in. We'll see you next time.